The following podcast is part of a certified educational activity titled Strategies for Immunotherapy Success in Non-Small Cell Lung Cancer: How to Incorporate Modern ICI Platforms Across the Disease Continuum. Access the entire activity and complete the post-test at peerview.com/AWM860. Downloadable slides and practice aids are also available.
All right, well, welcome everyone to this PeerView and LUNGevity educational event, Strategies for Immunotherapy Success in Non-Small Cell Lung Cancer: How to Incorporate Modern Immune Checkpoint Inhibitor Platforms Across the Disease Continuum. My name is Tina Cascone. I am an associate professor in the Department of Thoracic and Neck Medical Oncology at the University of Texas MD Anderson Cancer Center. I'm delighted to moderate with my co-chair.
I'm Heather Wakely. I'm from Stanford University, and really appreciate all of you joining us today. Hopefully we're going to make this a fun hour and a half, case-based education. And to join us in that are our panelists. Take it away, Julie.
Good evening. I'm Dr. Julie Bramer, a thoracic oncologist at Johns Hopkins.
And I'm Adam Schoenfeld, thoracic medical oncologist at Memorial Sloan Kettering.
Thank you so much, Julie and Adam, for being here. And thank you all for being here in person and online. The goals for today: augment your knowledge of the evidence that is actually supporting, right, the use of immunotherapy in advanced and in early stage non-small cell lung cancer. We want you to be really well equipped, right, with all the strategies to integrate immunotherapies in the non-small cell lung cancer treatment setting throughout the disease continuum. And we also want to enhance our ability, right, to work in a multidisciplinary setting to make sure that we can evaluate our patients collaboratively across all the multidisciplinary specialties to identify, right, the best candidates for immunotherapy and maximize the benefits for our patients. LUNGevity, as I mentioned, is our partner. They have done a tremendous amount of work to provide us with resources for biomarker testing. So please make sure that you later on scan this QR code to understand more about the material that is available. And for patients and their caregivers, they have done a phenomenal job to really educate us about immunotherapy and other clinical resources. And so with this, we're going to start with really the first case, and I'm going to hand it to Heather.
Thank you. Okay, so to make this exciting for everybody, what we've done is we actually have 4 different cases, and we're going to be talking about a lot of the data within the context of those cases. So please be ready to vote as we go through this. Our first case is actually going to be presented by Dr. Bramer. So Julie, take it.
All right. So we're going to focus on non-squamous non-small cell lung cancer and discuss this case. So this is a case lady who presented in my clinic. She originally presented to the emergency room with a 5-minute history of left-sided arm and leg weakness and some tingling. So she thought she was having a stroke. And she had also had noted a 2-year history of a chronic cough, but was told by her pulmonologist who actually saw her that they felt it was most likely due to reflux. And the MRI of the brain in the emergency room revealed a 1.2 centimeter right postcentral gyrus lesion with edema and a 3 millimeter right parietal lesion as well. They did do a CT of the chest that showed a 3.7 centimeter left lower lobe lung mass, as well as subcarinal adenopathy, as well as some right lung nodules, and the largest being 5 millimeters on the right. Her other history, she has a history of hypertension and hyperlipidemia, and she was a former smoker, smoked about a pack and a half for about 20 years, but quit 22 years ago. All right. So she came to the clinic. We did draw a Guardant. She underwent a bronchoscopy and a biopsy of the left lower lobe. That showed adenocarcinoma, poorly differentiated, TTF1 positive, negative for the markers for squamous, and our pathologist felt it was consistent with lung primary. Now, Unfortunately, the garden did not have any ctDNA to be detected, interestingly, even though she had metastatic disease. But after, usually it takes about 2 weeks for us to get back the mutations. The PDL1 was high of 50%, and the KRAS mutation was positive for KRAS G12C. So, what do you do? So, but now, slightly different scenario. Would your recommendations change? Same 66-year-old lady, former smoker, newly diagnosed metastatic lung cancer, PDL1 high, KRAS G12C mutation, but now she has, in addition to the brain metastasis, the left lower lobe, the small right lung nodule, now she has bulky liver metastasis and widespread bony metastasis. All right, so just to kind of go over just high level, for immunotherapies for PDL1 high disease across histologies, just looking at some of the data that we have for single agent and then combinations, and this is not all inclusive, but we have single agent PD1 or PDL1 inhibitors that have a very good median overall survival, nearly 2 years across the single agents, as well as response rates in the high 30s to mid 40% range. Again, this is for PDL1 high. And with ICI combinations, we are not seeing an increase in response rate, but we're also seeing a very similar, not quite 2-year overall survival with ICI combinations. So personally, in my practice, I've still used a fair amount of single agent ICI for patients with PDL1 high disease. So, for this case, for KRAS G12C, former smoker, PDL1 high, I personally, with minimal side effects here or minimal symptoms, we just have a primary brain metastasis with lung disease only. So really not a ton of disease. Obviously, she would get SBRT to the brain, those brain lesions, and then get in this patient's case, I gave her single agent IO. So, but certainly any of the drugs, pembrolizumab, single agent atezolizumab, cemiplimab, they all have great data. I certainly, particularly for PDL1 high disease. And then the combinatorial options, I think IO plus chemotherapy, you certainly can give if you're more comfortable. This lady wanted to delay the need of chemotherapy in this case. I do not use ICI combinations in PDL1 high disease, but that's just me. I'm not sure if any of you guys use IO combinations.
I agree, Julie, with you, and especially in this case, right, where, the patient has made clear to you, right, that platinum-based chemotherapy is something that, can wait, especially with the, median, numbers that you've shown us across the trials for PD-1 high. I think that makes a lot of sense. And although we have the dual combination, as you tell us, in some cases in PD-1 positive disease, we've actually seen activity in PD-1 negative disease as well. So I would be very cautious here in tailoring, more therapy, again, not necessarily better.
All right. But now, again, if this lady was in a different situation with bulky disease, widespread bony metastasis, that's when I get nervous. I need a response. More than likely. And so IO plus chemotherapy, I think, really does play a role in someone with a lot bulky disease, liver metastasis, where maybe IO only might not work quite as well. I certainly lean heavily on pemetrexed and platinum here in combination with IO, and certainly the cemiplimab plus chemotherapy or pembrolizumab plus chemotherapy. Again, I still don't use IO combinations in this setting. We're still dealing with PDL1 high disease, but I don't know if you guys have any difference.
Yeah, completely agree. I mean, in this situation, I'd be worried if I didn't give the chemo, they might not live long enough to derive the benefit from the immunotherapy. We really need a fast response quickly, and then hopefully they could still derive significant benefit from the immunotherapy. But in PD-L1 high tumors, there's really no clear data that dual checkpoint's going to improve over single with PD-L1. So I like to spare them that toxicity if I can.
All right, let's switch it up one more time. So what really happened? So again, this lady, same scenario, metastatic lung cancer. She does have, her tumor has a KRAS G12C mutation. But what if things are different? On your mutation report, it also shows SDK11, KEAP1 mutation, and now the PDL1 level is 0. All right. So just looking at IO combinations, and really in this setting with, again, this is all retrospective data that I'm going to show you for the SDK11 and KEAP1 mutations. But in general, when you see the IO combinations, in my mind, to break it down simply, is checkmate 227, you get to avoid chemotherapy. Checkmate 9LA, you decrease the amount of chemotherapy, which a lot of people are like, yes, only 2 cycles, I can get through that. And then the Poseidon regimen is, on the flip side, decreasing the amount of CTLA-4. So how much CTLA-4 do you really need? At least in this, with this data, they didn't need quite as much compared to checkmate 9LA or 227, where a patient continues on Ipi-Nivo for the full 2 years. But also the nice thing about Poseidon, you also continue the chemotherapy 4 cycles and then continue the maintenance. So I think that, look, again, this is really drilling down per patient, trying to decide, what do you think is important? What combinations is important for these patients? So, and clearly for both checkmate 227, which is approved by the FDA for PD-L1 positive disease, does have NCCN compendia listing for PD-L1 negative. Checkmate 9LA approved regardless of PD-L1 status, and then Poseidon the same. All right. And so for checkmate 9LA, the data is really, again, in my mind, tantalizing for PD-L1 negative disease here, regardless of histology. I really like this combination for PD-L1 negative disease, and particularly if I don't think a patient needs that much chemotherapy. In the first case scenario, this is in someone with PD-L1 negative disease, but low bulk of tumor, and I just want to use 2 cycles of chemotherapy. I'll use checkmate 9LA. Now, how about 227? We have 6-year data. Again, it's not FDA approved for PD-L1 negative disease, but again, long-term data with this combination, particularly for, again, in my mind, PD-L1 negative disease. Now, what about Poseidon? Here you can see across all subgroups, there you are seeing a survival advantage of the quadruplet tremelimumab, durvalumab plus chemotherapy. So, but what about SDK11 mutations? And Dr. Casconi is at the home of Dr. Skoulides and her colleagues, really who drilled down about SDK11 mutations. And at least for single-agent immunotherapy, patients whose cancers have SDK11 mutations really just do not seem to do well with single-agent ICI. But when you're starting to add chemotherapy, and you have a SDK11 mutation or KEAP1, it does seem to abrogate that same signal. And so you can see in Keynote 189, when combining chemotherapy with IO, SDK11 mutant disease can respond and have longer survival. Now for checkmate 227, we do see the same. Even without chemotherapy, you see patients with KEAP1 mutations as well as SDK11 mutations here. can have improvements in survival and improve progression-free survival, as you can see here for KEAP1 mutant disease. The trial that has looked at this more extensively, even more, is looking at the Poseidon group, looking at these subgroups. At the top left, STK11 mutant disease compared to wild type. You can see the combination of durva, tremi, plus chemotherapy, definitely compared to chemo, or even durvalumab by itself with chemotherapy. You can see that upper survival curve here for those patients who typically would not do well with single agent ICI. And then the KEAP1 mutation patients also doing better with the PD-L1 plus CTLA-4. And then again, looking even at the KRAS mutation patient subgroup, again doing better with the combination of durvalumab plus tremelimumab plus chemotherapy. So taking this, yes, it is retrospective data where there is a phase 3 study looking at the durvalumab tremelimumab chemotherapy combination in this patient subgroup of KEAP1 mutations or STK11 positive mutant adenocarcinoma. But right now in your practice, I personally like the ICI combination with chemotherapy in my practice. And in this patient, we discussed that with her, and she was willing to do it. So, but I don't know. Are you using this practically in the clinic?
Yeah, I totally agree with you. I think practically in the clinic, sometimes it's hard to get back some of the mutation data, and by the time we need to make a decision. So sometimes I don't have the STK11 or KEAP1 data, but the PD-L1 we certainly have. And I think for patients who are PD-L1 negative, where, I don't know how much benefit they really derive from IO PD-L1 with chemo alone, where it seems to be similar to chemo, the outcomes. I think dual checkpoint blockade, you really see that flattening of the curve even 6 years out with 227 and 9LA. So I go with dual checkpoint usually.
Yeah, same for me, Julie. I agree with Adam's assessment, and I really like the fact that you emphasize the differences, the subtle differences across the trials that are actually very important for our patients, right? The opportunity to only deliver 2 cycles of chemotherapy can be very attractive for some of the patients while continuing, right, the dual immune checkpoint. And then on the other end, for the Poseidon, where you have the full 4 cycles, so some patients will tell me, I want to really continue, right, and get to the 4 rounds of the chemo doublet, but have less, right, immunotherapy. So I have to tell you, I really enjoy, right, the opportunity to have the 9LA and the Poseidon, but that's definitely what we do across the trial for these patients with PD-L1 negative disease enriched with these commutations.
Yeah, I agree. I think that for me, that PD-L1 0, I have been convinced about dual checkpoint inhibitors. It took me a little longer than some other people maybe, but I'm there, and that's where I'll think about it. And I think the KEAP1 and the STK11, I mean, we have seen some variability in how that's come out. I tend to think of those as sort of poor prognostic factors, and I do tend to bring the chemotherapy in because I feel like chemotherapy can kind of, because it's coming in from a very different mechanism of killing the cells, it doesn't seem to be as impacted in some ways, though radiation is. So, so I kind of think about that, this is someone where in the setting where you do have both of those poor prognostic factors with the STK11 and the KEAP1 and PD-L1 0, this is a patient who really needs kind of everything, so the chemo and the dual checkpoint inhibitors. So,
and I think, Heather, what you said also lends a lot of support to the importance of the subgroup analysis, right? These are not really primary outcomes. We'll tend to go to the sessions, right, where the primary outcomes are presented, and we never want to miss those sessions. But actually, the subgroup analysis are so critical for what we do in practice. And so a lot of value there that I think it shouldn't be missed.
All right, I'm going to hand it over.
Thank you so much, Julie. That was so educational and so helpful. I think we continue to learn every time that we do these activities. So I'm going to move on, and it will be Adam and I, presenting and moderating this session. So Adam, take it away.
All right. So we're going to pivot a little bit, still metastatic lung cancer, but now it's going to be squamous lung cancer rather than non-squamous. So we have a 71-year-old Caucasian man who is newly diagnosed with a T2N2M1 disease with bone metastasis, squamous carcinoma of the lung. His PD-L1 expression was 60%. He's got emphysema on oxygen, and he expresses his desire for an aggressive approach, tells us, do everything you can do, doc. So here, Dr. Brahmer did a great job reviewing the data for non-squamous. I'm just going to highlight some of the pivotal data for squamous non-small cell lung cancer. So similar to the Keynote 189 trial, there was a Keynote 407 trial that had a 5-year update that showed similar 5-year overall survival benefit in squamous non-small cell lung cancer. And as you can see, if you squint on the bottom, you can see increasing 5-year overall survival, not unexpectedly, as you go up in PD-L1 expression. So very similar to what we see for non-squamous there. And then more recently, so most people know about the pembrolizumab study, but more recently, there's also the Empower Lung 3 study that has 2-year follow-up and also demonstrates overall survival benefit. And within the squamous, this was an all-comers population, squamous and non-squamous. But if you look in the squamous subgroup, you can also see an overall survival benefit and a progression-free survival benefit, very similar to what we see in the Keynote 407 study. And this is from the 2-year overall survival data. But as Dr. Brahmer brought up early, is chemotherapy really needed at all in patients who have PD-L1 expression greater than 50%? And that question I don't think has fully been answered when it comes to squamous or non-squamous lung cancer. And there's been some real-world data sets. This is taken from one of those real-world data sets that shows that while chemo and PD-1 blockade may improve response rates and progression-free survival in PD-L1 greater than 50% lung cancer, it's unclear if it actually improves overall survival. There's no significant difference in most of the real-world data sets that have been analyzed to date. And currently, there's an ongoing prospective trial, the Insignia trial, that's looking prospectively at chemo-IO versus IO alone in non-small cell lung cancer, but that has not read out yet. We do have data as well for pembrolizumab monotherapy in all histologies, and that also demonstrates benefit, as Dr. Brahmer had shown previously. But there's some unanswered questions as well. So, how do you deal with squamous in particular? Is there differences with squamous with single agent IO? Should I stop at 2 years? Must I stop at 2 years? And then what happens when the patient progresses on single agent? Should I continue the immunotherapy or with chemotherapy, or should I stop the immunotherapy, which wasn't really addressed in the Keynote 24 initial trial? More recently, in the Empower Lung 1 trial, the cemiplimab monotherapy trial, they showed that indeed also demonstrates an overall survival benefit in the combined histologies, and also in the squamous subgroup, there's a pronounced benefit. And this is a subgroup of a population of patients that we know traditionally does worse, has less treatment options, less chemotherapy options available to them. Further, if you look at the bottom of the design too, you can see when patients progressed on the trial, they had an interesting exploratory analysis where they allowed a subcohort of patients who progressed on the immunotherapy alone could continue the immunotherapy and add in chemotherapy. And so I'll touch on that in a few seconds. And then just to confirm that cemiplimab, it's one of the newer approved agents, but has the same safety profile consistent with previous results with other checkpoint inhibitors like pembrolizumab as well. And we talked about this a little bit briefly earlier too, the PD-L1 expression and how that's important. But one thing that I wanted to highlight here, and I think is also important, is that PD-L1 expression is a continuous variable. And when we group greater than 50% together, that's somewhat arbitrary. And there are some analysis to say that as you go higher and higher expression, you're even more likely to benefit from PD-L1 blockade. So, and they did this analysis in the Empire Lung 1 study, and we've seen it in multiple other analyses now, that as you get to a higher PD-L1 expression, somewhere on the order of 90%, you can see response rates greater than 60% for single agent PD-L1 blockade.
This is a great overview, Adam, of the data in this squamous histology. And just to recap, we have a 71-year-old gentleman with metastatic squamous carcinoma of the lung with a bone involvement with high PD-L1, so PD-L1 60% with some comorbidities, but overall the willingness to be as aggressive as possible with treatment. So we talk about monotherapy options as well as combination options. So definitely it seems appealing again here based on the data that Adam has presented to go with monotherapy, especially if there is not, again, that visceral crisis impeding right there, or if there is not a major symptoms burden. So again, I feel very comfortable in considering the monotherapy. And many times it takes, and Adam, I want to hear your thoughts here, because it takes sometimes to educate the patient that more is not necessarily better. So I want to hear your thoughts on this, because many times patients have a monotherapy. What about more than just two chemotherapies and one immunotherapy sounds so much better, doc, right?
Yeah, completely agree. I think that's always something tricky to navigate when, patients come and they say, do everything you can do. But, one thing to keep in mind is in this patient who, has a more limited functional status, if we give chemotherapy up front, we may limit his ability also to get immunotherapy if he develops some toxicity and has to be hospitalized. And so that may limit the do everything I can do for him in the long run.
Yeah, I agree. I agree. I think, do everything. Yes, the combination, it'll get you a higher response rate, but we're trying to help him run a marathon, not a sprint.
That's exactly right.
Yeah, it's interesting. We had a question from one of the audience members, and this patient who seems to be on oxygen at baseline, and how we're sort of thinking about immune-related adverse events, right? And sort of what are those predisposing things, such as being on oxygen? Are we at higher, is this patient really at high risk of pneumonitis or not? And does that change how we think about that? I thought that was a really intriguing question. I think it's always that balance, right? Is the oxygen because of the cancer? Or is there some other reason that they're on oxygen, right? Because that matters a lot. And it might weigh a little bit more on my choice of the chemotherapy, because I kind of look at it without the immune checkpoint inhibitor, the patient doesn't have any real chance of a long-term positive outcome. And yet with it, perhaps with that, there is a slightly higher risk. So the day's a little bit not so clear.
Yeah, no, absolutely agree. Again, it's all a matter of personalizing this data, right, and tailoring this data to the patient. But I think that was a phenomenal overview.
All right, so now we fast forward 3 years, and the patient, he was treated with cemiplimab and had a partial response as first-line therapy, was doing great, and stayed on the therapy for 3 years, but unfortunately, he had a progression of disease after 3 years of continuous therapy. And so we're going to start platinum doublet chemotherapy, but can we continue the PD-1 antibody? And so this is the data I was somewhat alluding to earlier, is that in this trial, the Empower Lung trial, for patients who had progression on cemiplimab, they were allowed optionally to continue the cemiplimab and the chemotherapy, and these patients were followed during that period of time. And what you can see here is their initial response rate with cemiplimab of 35.6%. And then after they added chemotherapy, second line, a response rate of 27%, which, while there's no head-to-head comparison to chemotherapy alone in this trial, is historically superior to what we might think of seeing for chemotherapy alone. Additionally, when you look at the duration of the response and the progression-free survival, so you look at these patients who received the added chemotherapy, they had a median duration of response of 11.5 months as well. So I think, a couple of takeaways I think of from that is this is the first phase 3 data we really have to understand anti-PD-1 with chemotherapy added at progression. It shows longer PFS versus historical data of chemotherapy alone. And it possibly allows someone like this for us to do everything that, he wanted. So we started with PD-1 therapy alone, avoids early chemotherapy without compromising survival in the long term. But maybe I'll open up, before I move on to some of the other things, maybe I'll open up to the group and see what everyone else thinks as well.
But I certainly, in this case, for those patients that you do single agent immunotherapy, this cemiplimab data does give me a lot more data and credence to add chemotherapy to IO when I need it, particularly in those patients where I don't feel like I need to start with it, but I can add it later.
Yeah, I agree. I do think there's probably is that synergy that we've seen. And so if we start with monotherapy, I do like to add the chemo too.
If it
ongoing.
progresses.
Yeah.
I want to emphasize something that Adam mentioned that I think it's very important if we actually try to disseminate this data with some deep understanding to our patients. If we had to give chemotherapy standard of care in the second-line setting here, which is our taxane, right, we're talking about response rates in the order of 10%, with a duration of response that is less than a half than what we see here at 11 months. So to have a 27% response rate at adding chemotherapy has our patient develop progression of the disease with immunotherapy alone, that's quite telling. And I think it's a very important set of numbers that I tend to spend time to explain to the patients, because it gives us some flexibility in starting off with a therapy that can be perhaps better tolerated in some cases, right? With, in giving the patient the opportunity to go on with their life without the impact, right, of the chemotherapy-related toxicity is not trivial to me. So I think this is, again, compelling data for a number of reasons that are actually very critical to our patient.
So I wanted to bring up another question that came up from the audience, and just out of curiosity. So we divided this, so we had non-squamous and then we had squamous, and sort of talking about the data in both of those settings. And the audience members asking, do you think there's really a difference between the squamous and the non-squamous and those outcomes, or not? And I guess I kind of look at it as the immune checkpoint inhibitors seem to work in squamous and in non-squamous, and the data is a little bit different, but then the data with chemo is a little bit different in those also. I don't really think about it mechanistically as being that different, except maybe, where I am practicing in California, if we see squamous, it's almost always in the setting of a smoking history. And when we see non-squamous, it's very frequently in the setting of not having as many different mutations, many of those with, driver mutations, a whole other situation, but sort of, like more complexity in the squames in some ways. But I don't know if any of you think about that differently, because I thought it was another really good question.
Yeah, no, I thought you're absolutely right, and you just, dissected very, very eloquently. I think that it's not just about the histology. The data seems to be, very much in alignment, right, with the chemotherapy, immunotherapy, or monotherapy, immunotherapy, in terms of, numbers, if we look at all the pooled data with non-squamous and squamous. But what matters to me, I think, more is what are the actual features of a squamous histology that might drive response, or non-squamous histology? What's the commutational status, like as Adam mentioned? And in squamous patients, you most likely don't expect, right, some drivers that you expect in the non-squamous histology. So that's how I approach it as I think about tailoring the treatment plan to the patients. But Julie, how do you feel?
No, I agree. I don't, really think, yes, it does seem like the non-squamous population in general does better overall, but we've seen that even when you look at chemotherapy.
And there is another question that perhaps Adam can I think is about to approach this, but I think this is a very relevant question. Would we continue immunotherapy regardless of the duration of the initial response?
Right. So you're saying if we
have an initial response to immunotherapy, do you continue for your 2 years? Do you go beyond your 2 years? Or do you stop earlier, right, than your planned 2 years?
Or what if it's only like 3 months?
If they've
only responded for 3 months or 6 months to immune therapy, do you continue it if you go to something else?
Yeah.
Like the two ends, right? Two ends of spectrum.
Right. I actually, if it's very early on, that's when I've often continued it, to be completely honest. So if a patient has progression at like an 8-week scan or a 9-week scan, and I just don't think that they've had enough time and they have a couple lesions that have progressed, that's when I've often added it in early. Later on, I find it trickier to decide when to add it, and I think it's often a discussion with the patient, but I'm curious what you think.
Yeah, it's about the same approach. I think early on you always give that benefit, right, of the doubt, especially if there is a stability of symptoms. But I think is that later on it is very challenging, and that's where again discussion with the patients is very important.
Yeah. And this perfect transition. This is what to do for the patients who have completed 2 years, because the trials often 2 years was the milestone cutoff for when you could stop the therapy or continue, and there isn't great data or randomized controlled trial data of what to do in this setting. So this is data from the Keynote trials, pooled analysis of patients who had stopped at 2 years and re-challenged when they had progression events. And you see the data is sort of mixed in terms of the response rate, about a 20% or 19% response rate in pembro monotherapy, and then patients who had previously received pembro chemo, or that one had a 0% response rate. Sorry, I'm having a tough time seeing the numbers from here. And then, one thing that I always find interesting, and a thing that I think is really critical to think about when you're re-challenging a patient, is what's that time period that they've been off of therapy for? Because what I'm thinking about in my head is this just a lack of exposure issue? Maybe they just haven't had the therapy for a very long time, or is this some mechanism of resistance that they've developed to the immunotherapy, and then re-challenge them really isn't going to be helpful. So what the data shows is that indeed with a longer time off of therapy, when you re-challenge, you tend to have a higher success rate with pembrolizumab. And we don't know what that cutoff time is for interval of re-challenge. Some people say 6 months, some people say 12 months, but definitely patients who have had longer time or 3 months longer time off of therapy seem to have a higher likelihood of having a response when you re-challenge.
I think this is a very important data. Again, it's all data from pool analysis and data that we look at it as exploratory analysis. But as Adam mentioned, those are very important findings to at least start making decisions in a personalized manner. So to recap here, we have a 71-year-old gentleman with metastatic squamous lung cancer with IPDL1 with bone involvement. He has comorbidities with emphysema. He's on oxygen, but he's willing to be treated pretty aggressively. Dr. Schoenfeld treats him with monotherapy, cemiplimab, based on the data with the PD-L1 60%. In the squamous histology, the patient achieves a partial response after frontline, and then as a progression, right, after 3 years of continuous therapy. So we talk about what we do in terms of, continuing immunotherapy beyond progression and what to do. So it seems like adding the chemotherapy, that's something that will make all of us, and hopefully many of you in the audience, comfortable now that definitely is an option. Adam, I think that's, something that you have very much emphasized with the Empower data. And then how long should we continue immunotherapy? That's probably one of the hottest questions that we have in practice every day. Julie, I'm curious to hear your thoughts here on whether you stop at the 2 years or you discuss with your patients. I know you quite enough to know that you have thorough discussions with your patients at that, benchmark. So tell us how you approach that.
Well, at 2 years, everybody gets nervous. But this is when I do a PET scan. If multiple things are lighting up, we got to get prepared. If nothing's lighting up, obviously I'd love to have a great MRD assay to even give me a better idea. But I usually stop when everything's cold. If 1 or 2 things are hot, then we might go in and do some radiation therapy or even resection, depending on what it is. But obviously, I wish we knew more about the mechanisms of resistance at that setting. Why at this point is someone's tumor becoming resistant. And I think some of the approaches that Adam's working on and others to try to see what to do next.
Yeah, Adam, tell us a little bit more about what we have on the horizons. You're definitely the guru expert there.
Oh, thank you. I think one of the things that I'm most excited about is some of the T-cell engagers that are coming. We've already seen in small cell lung cancer the approval of tarlatamab, which, for small cell lung cancer for so long, we haven't had really a new type of therapy. And I think that has been really a game changer for many of my patients. And so I think we could see that maybe coming forward in non-small cell lung cancer as well. We have the PD-1 VEGF bispecifics that are in trials now. And then I think there will be other ones beyond that targeting multiple different areas. And there's opportunities, I think, in engineering our own cells, similar to what we do with leukemia and lymphoma. I think there's ways to do that in lung cancer. We're already seeing success in melanoma and sarcoma with cell therapies. So I look forward to those approaches in the future as well.
Absolutely. I think we're all looking forward to those. And one question that came through the Q&A chat that I think is perfectly, timed to be answered based on what Julian and Heather mentioned. We don't really know what the mechanisms are, right, when we combine these therapies and what happens in the tumor. So Raj asked why STK11 and KEAP mutations predict poor outcomes with the immune checkpoint inhibitors. Well, we have the data, right, from all the trials. So Julie mentioned that Tuscalidis has been definitely a pioneer at MD Anderson in looking at the activity of a single combined immunotherapy with chemotherapy in these specific subtypes. I think what we know, there is still a lot of work to do, and I want to hear the thoughts of the group, but what we know is that definitely the presence of these commutations in the tumor wires the metabolic activities of these tumors towards something that is really not well receptive to shrink in the context of an immunotherapy delivery. And so I think that perhaps, Adam, to your point, those are the tumors where we really will want to see whether additional therapies, novel therapies might really have an activity, right?
Exactly. Yeah. I think, the cases we've talked about, exactly the PD-L1 negative expression, CK11, KEAP1 mutant, these patients have really a high unmet need because they don't benefit oftentimes from a lot of our standard of care therapies. And so I'm hopeful that these new T-cell engager approaches or cell therapies could be helpful in that setting.
Yeah, I think one thing, though, that we do know, and you're much more of the immunologist than I am, but that when we do have the PD-L1 negative, that by giving the CTLA-4, that actually can upregulate PD-L1 to some extent. And so that was another question that we had, but there is like a biological rationale there that by giving the CTLA-4 inhibition, that's going to bring up your PD-L1 levels and therefore theoretically help that PD-L1 inhibition to work a little bit better. That's the simplified version. I'm sure it's much more complicated than that, but at least to me, that kind of made sense. And that also helped me finally jump on the dual ICI bandwagon when we have the negative PD-L1.
I think, Heather, that's a great point because I think all of us on this panel are on, one of the latest actually manuscripts that tries to answer this question on how can we personalize treatments, right, when we have these commutations. And so, as Heather mentioned, from analysis from Poseidon or from other data, even in mouse models that at times are really helping us to look at mechanisms, we see that those combinations bring up some specific type of T cells with the PD-L1 that we wouldn't have without, right, the STK and the KEAP. So definitely some population of T cells that seem to be wired to be more effective in presence of these two commutations. So that was a great point. Thank you for bringing that up, Heather. So with that, I'll give it back to you, Heather, so that we can move forward.
Great. So we're going to move to early stage now. And Tina, I know you've got the first case here, so I'm going to let you... We'll move on and let you go ahead.
Thank you so much, Heather. This is now, as we mentioned, we're going through the continuum, right, of the disease. So we've definitely dissected the metastatic setting. Now we're moving on and see how are we applying this immunotherapy in patients that actually have an early stage disease, potentially resectable. So for this case, we have a 61-year-old gentleman, former smoker, who was found to have a left upper lobe mass. This mass was actually biopsy. It was referred to a pulmonologist and to an oncologist. and was found to have an adenocarcinoma with negative PD-L1, and the molecular testing was done on the tissue and revealed, again, to stay on the theme, a KRAS G12C mutation. You can see the CT chest with IV contrast at baseline that confirmed this left upper lobe malignancy, and also there was some concern for potential mediastinal and hilar adenopathy. The patient did undergo a PET scan, so a non-invasive mediastinal staging with an FDG avid mass of 4.5 centimeter, and with ipsilateral avid hilar nodal disease, but not mediastinal disease positive. MRI of the brain at baseline was negative. And then very quickly, in terms of a medical history that can be pertinent, hearing aids, GERD, family history, mother with breast cancer. He has a former smoking history, 20-pack a year, and he works as a jeweler. And he has an excellent performance status with really an exam that is unremarkable. And we wanted to highlight here the importance of having a phenomenal pulmonologist on the team who actually does look right at the other stations, N2 and N3, whether they need to be biopsy, would they look suspicious. So this patient did have that. So N2 and N3 disease were negative. So we have a T2B, a clinical T2B, N1 and 0. Patient has been evaluated by our surgeons, has done pulmonary function tests, and we have brought this patient to multidisciplinary discussion. These are the results of the FEV1 and the DLCO. And in the tumor board, our team members tell us that the patient is medically operable and is surgically resectable. Here, we really wanted you to see the landscape.
This is a very simple slide.
I love it. In TC. Very comprehensive for you to use as you will. But that definitely gives you all the material, right, to understand that the most important thing, to me at least, in that population of patients that comes to see us with potentially resectable disease is to perform genetic testing, right? You cannot not do that in 2025 if we want to get the best benefit from these treatments to our patients. And so for patients who have tumors that do not have what we call the AGA, so the actionable genomic alterations for which we have targeted therapies, or patients who have IO-sensitive AGAs, we have 3 approaches, right? As Heather mentioned, the neoadjuvant treatment, so with immunotherapy plus chemotherapy, up to 3 cycles followed by surgery. The traditional adjuvant treatment approach with surgery up front, followed by chemotherapy and sequentially immunotherapy. Although I have to say, I'm very excited to see at upcoming meetings, there might be some completed efforts where we have resection followed by combination of chemoimmunotherapy. I think the scientific is going to be so interesting to see what the differences, right, are. And then the perioperative approach, where now you have a sandwich type of opportunities. So you have a chemoimmunotherapy neoadjuvant, followed by surgery, and then continuation in all comers, right, regardless of your PD-L1, with differences, right, according to regulatory jurisdictions, but continuing immunotherapy for 1 year. And so here's the data that justifies all these possible approaches. So the CheckMate 816 is the pivotal, probably leading trial that has really transformed the standard of care for patients with resectable disease. Stage 1B at that time, because that trial had the AJCC 7th edition, so 4 centimeters or greater, or with nodal positive disease. So stage 3 at that time, stage 3A. You can see here using the pathological complete response as one of the co-primary endpoints, which is defined as absence of residual viable tumor in the resected specimen and in the lymph nodes. So your entire surgical specimen, 24% with nivolumab plus chemotherapy 3 cycles, as compared to 2.2% with chemotherapy alone. And I want to offer some context here because this is important when we interpret this data. And this is exactly what I tell my patients. Historically, if we look at the proportion of patients who gets a complete pathological response after chemotherapy, if you look at 20 years of chemotherapy, and Dr. Wakely is the pioneer in this, we know that that range goes from 0% PCR to 16%. So we used to think about a PCR rate traditionally to chemotherapy of approximately 4%. So here we have 2%, 2 to 4%. Now we have a 24%, so a quarter of the patient achieving a PCR. That's pretty encouraging. And then you can see on the right, on the top right, the event-free survival 4-year update, where you can see the separation of the curves that is, continues to remain pretty encouraging between the chemo-nivo as compared to the chemo, with, again, approximately a 15-20% of difference as we go over time of people being free from disease and alive. And then you can see at the bottom some of the, again, updated data. This is not the latest data. We will see the latest data just in a couple of days from Dr. Patrick Ford. We're all excited about this transformative data. We'll see. We know that from the press release, you'll see in the upcoming slides that the OS is positive for the CheckMate 816. But here you had the encouraging results of OS that are not yet cross the boundaries by protocol, right, to be statistically significant, but you can see how encouraging these results are. And then on the bottom right, something that is also important for our patients on cancer-specific survival. And again, you can see how the nivo chemo seems to be, favoring, right, an improved benefit for our patients as compared to chemotherapy. And so as I anticipated, the CheckMate 816 overall survival data that will be presented by Patrick Ford on June 2nd at 3 p.m. in the lung cancer session. I think we're all really wanting to see this data so profoundly changing the standard of care. Again, telling our patients now we know that these therapies will make you live longer, and that's very important from our press release. We have also trial in progress from Regeneron with a randomized study of neoadjuvant semiplimab plus novel agents and chemotherapy versus semiplimab and chemotherapy for patients with resectables. We'll see how this data plays out in the near future. And then what about the sandwich or perioperative approach, right, that Heather mentioned to you in the possible answers? We have several trials, at least 3 different trials that have been pretty much in alignment in telling us that this is another option that we can use as a standard of care for our patients. The Aegean trial, you can see here, although the panels are small, we wanted to provide you with material really to get the data and discuss this data with the patient. So EFS and DFS benefit by giving up to 4 cycles of platinum-based chemotherapy with durvalumab, PD-L1 inhibitor, followed by surgery and continuation of durvalumab for 1 year. And then you can see on the top right, the Keynote 671, which was led by Dr. Wakely and Dr. Spicer and colleagues. And you can see here the updated data, so the interim analysis 2 published last year with the EFS continuing to show benefit with up to 4 cycles of pembrolizumab plus chemotherapy in the neoadjuvant setting, followed by surgery, and then 1 year of pembrolizumab. And again, you can see there the co-primary endpoint. The Keynote 671 was the only trial across all these trials, so kudos to the team for having a co-primary endpoint that has the overall survival. So again, curing these patients and allowing them to live longer with this paradigm. And then at the bottom, you see the third perioperative trial, the CheckMate 77T, very similar design, up to 4 cycles of chemotherapy plus nivolumab, another PD-1 inhibitor, followed by surgery and 1 year of nivolumab. You have there the separation of the curves that is pretty much in alignment with the other trials. And then one little change, if we had to think about this patient with stage 3 disease and with N2 nodal involvement, we thought that perhaps could be very helpful for you to have this data. We know that the perioperative approach seemed to benefit patients with stage 3 disease. We have seen this across all the trials where you have a stage 3 single and multi-session. We see there a magnitude of benefit that seems to be very encouraging. We do see this also in the CheckMate 816. So definitely a population, when you have more nodal involvement, that you might strongly consider to disposition to a neoadjuvant approach as compared to an upfront surgery. And I feel, Heather, that the community is pretty much right in alignment, right, with that judgment call. So you can see the separation of the curves with the nodal involvement in favor of chemo, nivo, as compared to chemo alone. You will see on June 1st, so just in a couple of days, the updated data from the Checkmate 816 DFS update, the interim analysis of the US, and even more importantly, as we were talking about subgroups, right, the biomarker analysis by genomic profiling from this population of patients. And so.
Great. Okay. So a whole lot of data to think about. I think the key learning is that perioperative trials so far have really tracked very closely with each other as far as outcomes. And we're all really excited to hear about the OS from Checkmate 816, which is the only pure neoadjuvant study. So putting that together for this patient, this is a 61-year-old patient with a left upper lobe mass, which is biopsy proven to be adenocarcinoma lung cancer, 0 PD-L1 expression, KRAS G12C mutation. The patient has N1 station involvement. And what would you do at this time? The patient's been deemed to be operable and resectable. So your options would be resection and adjuvant chemotherapy, followed by immune therapy, resection plus surveillance, neoadjuvant chemotherapy plus resection, neoadjuvant only approach with neoadjuvant chemoimmune therapy together, a perioperative approach, or you're still not sure. So to think about that, just go through all of that in your mind. One question that does come up a lot clinically. So if you have a patient and they've had early stage lung cancer that's been resected and they've had chemotherapy and immunotherapy, whether it was just neoadjuvant, just adjuvant, perioperative, or let's say it's stage 3. They've had their chemotherapy radiation and then they've had their year of durvalumab and then they've recurred. What do we do? Do you bring back in immune therapy? Does it matter on timing? And what data do we have? And that was one of the questions we got. I mean, to me, the data is all of the trials in the metastatic setting allowed for patients who had had immune therapy if it had been more than a year that had passed, but we don't really know the answer if it had been less than that, right? So I guess in practice, what do you do? The first thing I do is make sure we've looked at their driver mutation because those are the patients I see. And if they didn't have a good response to their durvalumab for stage 3, oftentimes there was a driver mutation that wasn't known, or perhaps it just wasn't known at the time they started their neoadjuvant chemotherapy, immune therapy. So that's the first thing I do. And then there are other things that you all think about. I took that easy answer, so I'm going to give you guys a harder one.
Yeah, the next thing I think I do is I look at their initial response as well. So if they had neoadjuvant therapy followed by surgery, did they have a good response to the therapy? And then after that, I see how long has it been, as you said, is if it's less than a year, there's still a difference between like 2 months versus 10 months. So I think for patients who have progressed very quickly after completing their therapy, I'd be a little bit more reluctant to just do the same therapy again. But for patients who are close to a year or further out and had a great response initially, I think I would be much more inclined to re-challenge them with that same therapy again or something similar.
Yeah, I agree. Perhaps I think, Heather, like you are definitely looking at the molecular profiling in detail. You know, many times we rebiopsy this patient, even if we are not in the context of targeted therapy, we rebiopsy this patient and see what are the acquired mutations they might have had. Julie, I don't know whether you feel that that's something that's critical.
I've even had patients have developed small cell lung cancer within a year or two. And I think a lot of times we see patients who have heterogeneous disease and then develop that. Or again, a lot of these patients do probably have adenosquamous disease. And if one part of the disease then is treated and it works well, but then another part comes back, sometimes we'll see someone who we thought had pure adenocarcinoma actually develop squamous down the road.
Absolutely. And I look at the timing, as Adam mentioned, but Heather, one thing I wanted to mention is, to me, the magnitude of progression and the pattern of progression matters so much, because it's one story. You have a local recurrence that can be assessed, right? Surgically, it can be assessed with radiotherapy. You have a, disease everywhere. Many times, correct me if I'm wrong, if you see this, I'm seeing a lot of oligometastatic disease to the brain. And so those are patients who are disposition to SBRT. And then if there is no extracranial, disease, many times I continue surveillance with, very active MRI scans. So those are all factors that are critical to make these decisions. Okay. So this patient receives, as we all agree, I think, at least 3 doses of neoadjuvant, chemotherapy with carboplatin and pemetrexed for non-squamous histology plus an ICI. Developed mildly symptomatic COVID, but we were able to stay on top of things after cycle 2, was able to receive cycle 3. And this is very staging scan, so definitely you can appreciate that there is a response to treatment. In many cases, there is a discussion again with the surgeons whether that's fully in a repeat multidisciplinary setting, or many times in the multidisciplinary clinic, we tend to have that, to reconvene, right, with the surgeons for the assessment. And this patient underwent surgery. As you can see here, the patient was able to remain an N1 disease and had PD-L1 10%. So slightly different than what we saw at baseline. It was 0%, so don't be surprised to appreciate these differences. Remember that at baseline you have a biopsy. Here you have an entire tumor specimen. Chemotherapy has been shown to increase the PD-L1. So that's something that we wanted to point it out for the sake of discussion. And then you have residual viable tumor. So remember, the pathological response can be seen as in a dichotomic manner. So you can see it as a categorical variable, a response yes or no, 0% or more than 0%. Or you can see it as a continuous variable, right? As Adam mentioned about the PD-L1. So a continuous spectrum that definitely allots the patient in a different bucket, right? And so you can see here we have a residual viable tumor, 61%. So there is some treatment effect, but there is some magnitude of residual disease. And this is an R0 resection. Thoughts?
I'm looking at you, Adam.
Or Adam.
Yeah, either of you.
I always struggle in this situation, and I end up having a long conversation with the patient, going over that we lack the data to know, because we have no results from a head-to-head trial right now. So it's possible that doing more may be helpful, but it's also possible it might just increase risk of immune-related adverse events. And so it's usually a decision made with the patient. And part of the decision making too is, did they have toxicity initially? How hard was it to get through that treatment? Are they how fit are they, and what they want to do in that situation for me.
Yeah. And stay tuned. There is a cooperative group ECOG ACRIN trial called CLEAR that will be randomizing patients who did not have a complete pathologic response after neoadjuvant chemotherapy, and they'll either receive single agent IO or IO plus another combination therapy drug.
Great, thanks, because we really don't know.
We really don't know. I think this was great discussion, and before we go to Heather, I just wanted to add that I was a little bit tricky by giving you the PD-L1 10%, but just because I wanted to tell you that, don't be surprised if there are those differences. But although we don't have a head-to-head comparison data, we have seen across the trials that perhaps in absence of an escalation strategies in this case, so if you have a trial, which there are many trials ongoing with vaccines, right, and other intensification strategies, it seems like continuing treatment in the PD-L1 0, in the PD-L1 negative population, might provide some comfort, right, when we look at that separation of the curves. But again, this is all exploratory data. And then the last thing before we pass to Dr. Wakely for her case, we just all wanted to remind you about the subcutaneous formulation of the immunotherapy. We have the Atezo approved. The Pembro is under regulatory review in US and Europe. And then we have data that will come out or is cooking right with the nivolumab as well.
Yep. Actually, I saw that on TV the other day.
Oh, look at you. I've not seen that one.
Yes, about subcutaneous nivolumab being available so you can treat your own cancer.
That is
great.
That's
Great,
yourself.
great advertising. Okay.
Don't need expertise. So with this, we'll conclude this case. And I want to thank Heather for being a great moderator. And then I'll give her the microphone for the next case.
All right. Thanks. So don't worry, we won't take quite as long on this one. So we will get you out of here on time. Okay, so this is the last case. And this is a patient who actually had a smoking history and went in for screening and was found to have this nodule in the left lower lobe. A CT-guided biopsy showed that this was moderately differentiated squamous cell carcinoma. CT scan confirmed that left lower lobe mass, and a PET showed that SUV was 5.5. There was no uptake anywhere else. MRI brain was negative. So, thinking about, and you don't have to vote here just to think about it, additional tissue testing needed? No, or I would get PD-L1, I'd get PD-L1 EGFR ALK, I'd get PD-L1 and next-gen sequencing. All right, so the PD-L1 was 55%. No driver mutations were identified. The patient had a left lower lobectomy within 1.9 centimeter moderately differentiated squamous cell carcinoma, and 3 out of 8 lymph nodes, hilar nodes, were positive. Sorry, these were intrapulmonary nodes. And they all had the same squamous cell carcinoma. No mediastinal nodes were involved. And I think it's important as we talk about all of the benefits of neoadjuvant chemoimmunotherapy to recognize that there are a lot of patients who are still going to be going straight to surgery. And so it is important that we recognize that that is still happening. I think that for those of us who practice in academic centers, we like to emphasize the importance of having those multidisciplinary tumor board discussions. I think for people practicing in the community, that's more and more common. And there will still be cases who go straight to surgery where the nodes were hiding, nobody suspected them. And, and sometimes that's still a reasonable approach as well. I always like to make sure we do talk about, well, what do you do when that happens, right? The patient's already gone to surgery. All right, well, I'm going to go through the data quickly here. Great. Okay, so you probably can't see those slides very well, but I'm going to talk through it. So we want to remember that we've now had 3 large trials with adjuvant immune therapy. There are others we haven't seen the data yet. Keeping in mind when these trials were designed, we had not yet seen KEYNOTE-189 or any of the other trials in the metastatic setting showing that giving chemotherapy and immunotherapy together was actually beneficial. So we are now doing some adjuvant studies looking at those combinations, but all of the adjuvant trials gave sequential therapy because that's all that we knew to do at the time the studies were designed. As someone who's done a lot of adjuvant trials, they're fabulous and they take forever. And by the time you get answers, there are things you wish you had done differently, but that's the way the trials go sometimes. So of the trials, Empower 010 with atezolizumab, we now have 5-year data, which I got to present last year at ASCO on a nice poster. And we do see that you do have continued disease-free survival benefit in patients who have PD-L1 expression in their tumors of any level. And that's actually amplified in those with PD-L1 greater than 50%. Hazard ratio is still less than 0.5 in that setting. For overall survival, because the study of the way it was designed statistically, we can't really claim any overall survival, but the trends are seen pretty clearly in those with PD-L1 expression of at least 1% and much more so in those with greater than 50%. So take that as it is an approved option in these patients with atezolizumab. Then with pembrolizumab, we haven't seen as much long-term data, expecting to see that, but the study was positive regardless of PD-L1 expression, which was a little bit confusing, given that in other trials with pembrolizumab, we've seen that PD-L1 level quite important in metastatic as well as in earlier stages of disease. But positive trial for that disease-free survival endpoint as well. So for those of you who voted for atezolizumab or pembrolizumab, yes, those are both approved, would be very appropriate in this setting. Then we had this BR31 trial with durvalumab, where we know that durvalumab is a very active checkpoint inhibitor. We know it's very effective after chemo radiation in stage 3, and yet this was a completely, absolutely negative trial. So that has confused us quite a bit. But you've got 2 positive trials, one with PD-L1, very important, one regardless of PD-L1, and now this negative trial. So that pure adjuvant, when you give the checkpoint inhibitor after chemo, is, I think, a little bit of a confusing situation. But we have these patients, they show up, what do we do? I think it's reasonable to give them chemotherapy and immunotherapy, and hopefully someday we'll be able to give those in combination when we have the data. So that's sort of how I would summarize this. Okay, so then.
That was a great summary, Heather. Succinct and effective and just hitting the key points. So we have a patient with left lower lobe nodule found at screening CT, which thankfully, right, is taking us to this scenario so much more often. PD-L1 positive and high, no driver mutations identified. This is a squamous cell carcinoma, less than 2 centimeters, taken to surgery, and with disease found at surgery in the intrapulmonary nodes. With squamous histology, there's no mediastinal lymph node involvement. So again, we have different options that we could have chosen. I have to say here, with someone who has such a small amount of disease, and really with the opportunity to go up front surgery and then decide what to do with a surgical specimen, that's something that we would have contemplated here as well. But I don't know if Adam and Julie had a different approach. And also in the community, I think things are done based on patient needs and, tailoring these algorithms to patients as well.
Yeah, someone with just a solitary nodule, they'll end up going straight to surgery. Some won't even biopsy. If it's hot on PET and there's nothing else, they'll take them straight to surgery. So, and I think, in the adjuvant setting, the chemotherapy now, this harkens back into the early 2000s, trying to decide which chemo combination to give to a patient. And that's really an individualized decision about what toxicities to avoid. I like cisplatin unless I'm worried about somebody's kidneys. And then on the flip side, if a patient doesn't want to lose their hair, I'll stick with gemcitabine regimen. But someone who doesn't care, or I'm worried about their kidneys with platinum or hearing, then I'll stick with paclitaxel and carboplatin. But I don't know, Adam?
Completely agree with everything you said, Julie.
I would give chemotherapy, though.
I think we all agree.
Yeah.
Please give chemotherapy.
I would give
with
chemotherapy.
the nodes,
Nodes positive. There is a pretty much about 60% chance, right, of relapse here. 50%, 60%. So please don't neglect, right, this rates of recurrence. And I think to Julie's point, we get all the time these questions: carbo or cis. I think we were all very much more adamant about having the cisplatin, right, in this adjuvant setting. I think that in the neoadjuvant perioperative era, with the data that is emerging with, efficacy with the carboplatin that is pretty much in alignment with the cisplatin, we're a little bit more comfortable, right, in switching because the efficacy is going to be there. There is more compliance. So definitely learning, right, from the neoadjuvant and perioperative to tailor these therapies. And then, as Heather mentioned to you, you have the opportunity to give immunotherapy. Here you have a PD-L1 55%, so the atezolizumab would be something that you are, absolutely able to give FDA approval with PD-L1 positive disease. 50% for the European, and then pembrolizumab all comers. But again, if you look at the data and dissect the data here, the atezolizumab is something that will make a lot of sense to give. So definitely a lot of options for these patients. And as Heather mentioned, we'll see in the near future whether combining chemo and immunotherapy in the adjuvant would do something even more. This is something very quickly that Heather and I wanted to bring to your attention from the LUNGevity. Again, with all the efforts that I have put forward, there is the material, educational resources for understanding the Medicare's lab testing billing rules. There are different rules for inpatient, outpatient, a 14-day rule. Please feel free to go and learn more about these rules from LUNGevity. And then take the survey. We're still in the 14-day rule. Please use the QR code to scan. And this is just a 3-minute survey that you can pass along to your colleagues. And it's just educational material to know more about it. And the first 300 will have $20 Amazon gift card. Thank you very much for being here.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, LUNGevity Foundation. This activity is supported through independent educational grants from Bristol Myers Squibb, Merck Co, Incorporated, Rahway, New Jersey, USA, and Regeneron Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/AWM860.